to our podcast this evening. Dr.
Excellent.
Friedel, thanks for joining me. Dr. Baran, Erdik, our regulatory advisor.
Hello, my name is Dr. Joseph Friedel. I'm the CCM liaison for the company, so I handle all intercommunication between the company and also the client practices. So I will now hand it off to Dr. Baran as well.
Thank you, Dr. Jayaswal. Thank you, Dr. Friedel. I am Dr. Baran Erdik, and then I am in with CCM with a regulatory capacity on regulatory compliance. I handle everything to do with CMS, and then everything to do with EMTALA, conditions of participation. So if you guys ever were in a hospital or a similar facility and were scared that the state was coming or CMS coming, they usually if not myself. So that gives me a good understanding of what the current trends on the regulatory aspect is and where everything else is coming from.
Great. So I'll introduce myself, a little bit of my background. So I am an emergency physician. I've also done general surgery, quite a bit of cardiac surgery. And if I have the chance, I will go over that. But the idea is to introduce my background. I am now Chief Medical Officer, bringing my experience to what is now population health, value-based care. And we'll dive straight into the subject matter here. So Dr. Erdik, please.
Okay, I mean, we're here to talk about what's been happening in the regulatory scope, right? With that said, the most important thing becomes value-based medicine, value-based purchasing. It's the buzzword that all y'all, Dr. Jayaswal, Dr. Friedel, and all of our esteemed attendees would have heard. What is it? Why are we even here? Why are you guys in a studio right there? Well, this is the buzzwords that you need to know to see where this is all going, right? So the quality payment program, the merit-based incentive payment system, the alternative payment models, etc. So I'll mention these briefly to give you guys an overview, and then that way Dr. Jayaswal can take it from there and then see explain what we do at CCM Health and so on. These are the 5 key things that you all should be knowing. So first one is the MACRA, Medicare Access and Chip Prioritization Act of 2015, basically changing how the payment landscape is and what CMS has decided to do with it. I mean, depending on the age of our attendees, if you were practicing medicine in the 1960s, 70s, 50s, 40s, sky's the limit. You saw a patient, you billed them, and that was it, right? I mean, that was a transaction. It's like you go to the store. Oh, can I have a pound of candy, please? Sure, here you go. Oh, hello, doctor. My chest hurts. Can I have a prescription, please? Oh, sure, here you go. I mean, that obviously didn't work, right, guys? I mean, Dr. Jayaswal, you said you've done a lot of surgeries. It wasn't working. What did CMS say? They said we need value here. We need added value. What are we going to do? So basically, they created a scoring system based on how well you're doing, based on your quality. So based on if you're actually demonstrating quality on how you're doing. It's like an MPG of a car. Would you rather have a car that has 20 MPG or would you rather have a car that has 30 MPG? So same perspective. And with that sub certification you all can get, especially if you're in a primary care setting, it's called PCMH. It's like the JCO accreditation, similar for a hospital. It helps you score really good, so you'll get added benefits, and then it shows to the world that you're certified, right? It's like you're looking for a car, you go to the webpage, oh, this one is 5-star rated for the crash test. I'm gonna get that one. Okay, so ultimately, this all boils down to AAA. For those of us that can remember, there was a lot of discussion in like 2000s. US was billing a lot, not showing the returns of such high costs, and among the OECD countries, we were the ones that utilized the most amount of healthcare, didn't have anything to show with it. Basically, it was administrative costs to the moon. So then came AAA, meaning we needed better care at a lower cost and improving patient experience. And the Affordable Care Act sort of all started driving this, because ultimately in the US, if you think about it, I mean, no one really dies on the street corners, right? If you see someone, what are you going to do? Call 911 if you're not a physician and you don't want to administer aid? Sure, then what's going to happen? I mean, there's EMTALA. If an ER doesn't treat them, I'll be there to penalize them. So they better treat them, So at the end of the day, everyone gets some sort of health. But the question then becomes, we want to ensure that these chronic diseases are managed from an early on perspective, because a ounce of prevention is worth a pound of cure. So if I let a diabetic patient get into ketoacidosis, I mean, sure, in 2022, even though there's an ongoing war, there's this, there's that, we still have technology to treat ketoacidosis in an ER setting. That's fine. I mean, I can give them insulin, whatever. But wouldn't it be nicer that we prevented people from going into ketoacidosis in the first place? So that's how it all comes together into chronic care management. And then that's sort of the introductory background to what we do here at CCM Health. I mean, I've been talking here a lot, but I mean, if you want to look at MACRA, it's replaced the sustainable growth rate formula. Basically, the new approach. It's basically the new era. So basically, you are tied on 6 different goals, which are improving your outcomes, enhancing your experience, increase in advanced alternative payment models, which is another webinar we have online. If for those of you that are interested in that, we're more than welcome to go to YouTube for the CCM Health page and look those up. Promoting the program understanding, as well as improving data and information sharing and ensuring operational experience. So these all sound like buzzwords, right? But I think there is one key that brings it all together, and that's chronic care management, and that's what we will discuss. You may also remember these. Some of you may have participated in these. Ultimately, these were and still are, to an extent, what you're living with. So you were living with the value-based modifier. We're living with the EHR incentive program and meaningful use. This is not her, this is EHR. PowerPoint, if you've ever tried typing up EHR, will constantly change that to her. So if Microsoft is attending, please, please, please fix that. Then we have the physician quality reporting system, the PQRS, and ultimately these were all sort of converted into the MIPS. I mean, if you're billing less than $90,000 for Medicare, or if you have less than 200 covered entities, I mean, you don't need to worry about this a lot. Those are exempt. You could have also opted out. I mean, with the worldwide pandemic, they gave a lot of leeway on the leash, but that is also going away. So the penalties are going to come soon. And those penalties are up to 9%. Technically can get up to 27, but unlikely to happen. Same thing with the reimbursement, because this was essentially designed as, oh, Dr. Jayaswal is really doing good, right? Dr. Jayaswal, Dr. Friedel is not doing good. I'm going to take Dr. Friedel's money and I'm going to give it to you. So this was designed to be budget neutral. But with that caveat, it hasn't necessarily been. There's been lots of changes in it, but ultimately, if you're a good boy, if you are going after that carrot, you are looking at a 9% reimbursement increase, 9% bonus. And that is why you should care, because if you're billing $1 million, 9% is $90,000. And that's not pocket change. So it adds up. And year after year, you can't, it's not going to be cost effective to be in the penalty area. It's not going to be really sustainable to be there. And that's the outcome. I think they're trying to drive out those people that either don't care, don't know how to care, don't have the resources to care, or can't just do anything about it. So they keep losing and losing and losing. And I think chronic care management is the key here. And then that's what we are here for. And that's what we think the start-stop key for value-based medicine is. And with that, I return the microphone to Dr. Jayaswal.
Absolutely. So Dr. Friedel and I, we have, of course, on our daily routine meeting providers. One thing I would like to start out with talking about CCM is the amount of information that still needs to be passed on to the other side of the table. That is, what is CCM? What exactly it brings to, of course, the patients in detail, and the provider and the practice.
Dr. Jayaswal, let me stop you there for a second. We are getting some questions here. Guys, I'm going to keep track of all of them, and then we will get to the questions at the end of the session. We'll have a free discussion.
Sure thing.
Sounds good.
So I will, the slide is pretty summarizing it. We can talk much more, and hopefully we'll have the chance to do that, Dr. Friedel and myself, with you in person. So by yourself on the left side of the slide here, of course, you can do stuff for sure. That's how it's been happening. And then on the right side, if you see what you can do with the help of a support team like ourselves. So on the left side, you create your team, you acquire all the regulatory information, and you put them in practice by yourself. We're talking about PCMH, MIPS, compliance.
That's
We're
right.
talking about the MACRA that Dr. Erdik went through.
Or basically bringing the infrastructure of the chronic care program.
Yeah, so we actually bring all these in a manner where you are not going to be having to focus on those, because we have the expertise. So it's like a turnkey solution. So the team of medical personnel, we're talking about, looking at care gaps and closing those care gaps. Sorry. We are talking about PCMH MIPS, which Dr. Erdik is our regulatory expert who will be at the disposal of our partner providers, and the guidance how to get those plus 9% of MIPS. How do you position yourself? You have position in order to get it. Otherwise, you're not getting it. You're going into the minus zone, and it's straight -9.
I mean, exactly. It's one thing to sit there and look at a map, or right. It's another thing to actually get there. So we are sort of the navigation system, I guess. You put the destination in, and we'll get you there.
And what about upfront costs?
Yeah, so we actually make it as part of the strategy to partner that there is no upfront hurdle, financial hurdle. So, we're talking at the end of the day of population health. So we want to do,
we're establishing the infrastructure with no upfront costs there. Yeah,
exactly. Very important point. It should not be a financial hurdle that we go forward with a collaboration, because there's a lot of ground to cover. We can talk long about, the healthcare system in America. So at least as far as the collaboration goes, there is no hurdle financially to overcome to get going. So we are talking about, this is a very, very packed slide. I'll just, tell you what CMS says as far as chronic care management. So, it is part of CMS's strategy to have prevention, because we are talking about a very big elephant in the room. I mean, elephant is already big, but so they want to, the path forward is, the name of the game is prevention. So chronic care management is education, oversight. We're talking about chronic diseases. The biggest one is diabetes, followed by cardiac diseases, followed by the whole host, cancers in there. We're talking about multiple sclerosis, apnea, pulmonary diseases. So all these diseases need to be managed. And the way forward for Medicare is to put the emphasis on chronic care management, CCM.
Exactly. So on average, elderly patients have about 6 diagnosable disorders. So basically, if it's there, you'll find it. So there's a lot of chronic disease out there.
So we are talking about, of course, the patient-provider relationship, but then we come in and then we become the third partner. It's like having a hospital at home. So you have a nurse who is looking after the patient, and it can only be better. Statistically, it's also there. We'll go over the numbers. And let's not forget revenue increasing for the provider. So you're incentivized to do prevention, because down the road, the system is going to pay a lot more. So the idea is to incentivize with more financial incentive right at the beginning, where it can be prevented. So very important also to highlight that. So the staffing and the tech investments, of course, we take care of that, because that should not be the hurdle going forward. So again, talking about hurdles. So the guidelines of CMS is that there has to be a certain a minimum of 20 minutes of that tele visit by the nursing with the patient. So we are talking about a minimum of 20. But we're talking of geriatric population, so with multiple comorbidities. So this 20 minutes is very, very limiting. So the idea is to have a conversation, because the most important thing is, we'll come back to that too, is to have a certain bond that's created, because that's what makes for quality care. So a nurse becomes part of the family, because we have the same person dedicated to the same patient. So the nurses will be part of the family. That creates also that recurring televisit, And of course, it's not just once, it can be twice, 3 times calls per month, depending on necessity, and also depending on quality measures. We will come back to that, because the quality measures needs to be selected at the beginning of the year. So I don't know if providers have you selected your quality measures. So
So with that 20 minutes, maybe a little bit clarification. That's the minimum to be able to build that code, right? The CCM chronic care management code,
Yes.
which is 99490. So, but that's also non-clinical 20 minutes.
Yes, absolutely. And one word on the EHR, because without technology, there's the human component, and then you have the technology. Without the technology, so we are having at our disposal a proprietary software, which is very intelligent. Important to mention it because it's a CCM geared platform. So it allows to do the CCM, reducing the risk, reducing the hospitalization, the readmissions. That's the goal of the technology. There's a lot of EMRs out there. This one is very intelligent. It piggybacks on just about any EMR. So we are talking about a chronic care management geared platform. Talking about platforms, so CCM Health has this strong investment over the years in technology. So we have data science, we have machine learning, we have AI, all these things. You have to keep in mind, this is the reason why we are able to do population health in the 21st century is technology. Without technology, we won't be able to. We'll be back to what you used to be before. We used to be doing before. So it goes down to legislation now, value-based care, which is the payment system based on prevention. And once you understand how it works and you understand that technology is the foundation of that, we are able to make the best out of it. And the biggest gain is for patients. I mean, having technology at the disposal of these chronic patients, diabetic ketoacidosis, one hospitalization cost, the number is astronomical. So even a tenth of that cost, if it's incentivized upstream by following patients, making sure that the A1C levels are going down, and the patients are taking their medications, the medication is calibrated, all these things we do. There are visits that we make sure that is happening, fall assessments happening every now and then, glucose monitoring, pain assessments, medication reconciliation, BMI, all these things will be taken care of, so providers can focus on other things. This is something which is very much in the realm of our nurses. So this is what they are very good at. So you will be having this component in your practice. And we have a score of an NPS score of 75, which I'll come back to that, which is the benchmark. We outperform that.
Let me take over now, Dr. Jayaswal. So Dr. Jayaswal has alluded to some of the different things that we're doing here at CCM, and one of them is that unique CCM platform. So that is exactly what you were talking about with our CCM EMR, with its unique machine learning. Part of my job as liaison is basically coming into your practice, and we sit down together and I teach you the system as well. So I know when I see a lot of clients, there is an initial fear in regards to kind of new technology, and that's okay. That's just fine. That's exactly why I'm here, to help educate and help learn with you in regards to the CCM EMR. Another thing is quality control protocols. Our QA/QC group, that's a part of our CCM group as well. They are basically there to make sure that all care plans are our clinical documents that our nurses are creating monthly. Dr. J was already kind of alluding to the fact, they're doing a fall assessment or they're doing a pain assessment. QA/QC is designed to look at all these documents and make sure everything is quality, because if you have all these tools, that's all well and good and you're utilizing them, but you also have to make sure they're utilized properly. So we're always improving and we're always looking to improve. So that's why quality control is such an important aspect of our program as well. So education for patients, this is key. This is paramount. This is something that we're very good at doing. Our nurses, I want to mention, when we start hiring on staff, with our current clients, they will meet the nurses first. They will interview those nurses and they will decide if they should be a part of the team. We are your hands. You are the head. And so basically, as Dr. J already kind of said, I already see guardian angel. That's the kind of the idea of the nurses. They're watching the patients monthly, calling in, checking in on them, and then also opening up care gaps. Now, care gaps we have not discussed yet. A care gap could be anything as simple as the patient hasn't seen the provider in over 6 months, to they haven't had their hemoglobin A1C checked in over 3 months. Basically, when the nurse finds this, it goes into our proprietary software, and you're able to look in on that 24/7, and we go over together, and you decide how you want to handle that. So once again, guidance for doctors as well. We definitely want you to know with our care gaps and all hospitalizations. So every morning I meet with my clinical staff. The first thing I ask, are there any new hospitalizations among my current clients? That is my number one question. I ask it all the time. And if there's not, fantastic. And if there is, the next question is, was it preventable? Because if it's preventable, then that's something we definitely want to explore. And hopefully we can stop that from occurring again. Because isn't that one of our goals, basically?
Absolutely. So the idea is to go after those preventable hospitalization. A car accident is
not really, or like COVID related ones. We can't really do too much about that. What I find with our current clients, it's usually fall risk. And that's usually really the big thing. Falls are the greatest hospitalizations that we have in regards to the
geriatric population. So we're talking about
changes your life, right? You break your hip, you're done. Like it's recuperation is an issue. There's excess mortality. Yeah.
And I can't tell you how many times our nurses have just found like just these, I don't want to say deficiencies, that's not a nice way of saying it, but they'll find out that maybe the home health aid's not really paying attention to the patient, or maybe there haven't been any kind of environmental checks, like are the throw rugs there, are they taking them out, are there bedroom guards with the rails? Sometimes there's nothing being done. So that's a great way of being able to key in and let you guys know what's going on, because listen, you have a big patient population. You can't know what's going on with all of them all at once. And so that's why we're really key in being able to provide you that extra insight, an extra pair of eyes, if you will, in regards to looking in on your patient population. And so that proprietary technology we were kind of talking about, I won't belabor the idea with the CCM EMR. We kind of went over that a little bit. Another thing we do is RPM, remote patient monitoring. And so we have glucometers and blood pressure cuffs, excuse me. They use cellular chip technology, so they don't rely on Wi-Fi or anything like that. The idea is that you're seeing a patient and you're getting their readings, maybe once every 3 months? Depending on the patient. What do you think?
I mean, I think that's good. Otherwise, half the office phone calls would be, how do I connect this to the Wi-Fi? My nephew set the Wi-Fi up. I forgot the password.
Exactly. It's made to be technologically as simple as possible for people like me too. Seriously though, there is one button, only one button. All the patient needs to do is push on that button, and then that data is transferred to our CCM EMR remotely, and you will have access, of course, to that data 24/7 as well. So you're getting a broader, more detailed clinical picture in regards to your patient's health. Another example, like I had a current client where we're using this technology, and basically they were just seeing that their systolic BP was just out of control. They were actually able to see this every day. And so they adjusted the medications, and actually, I think over like a month or so, we started noticing an improvement. So it's really cool just to be able to see how you can fine tweak some of these patient scenarios and actually, improve patient outcomes. And of course, the ultimate goal, reduce hospitalizations.
Yeah. So one word here is the social determinants of health. So we actually make sure that, if you're starting a RPM program, that we are actually making those devices available. And then we try to, down the road, try to have the reimbursement of those costs. So social determinants of health, that we won't have time to go into the detail, but there's a Harvard study that came out earlier this year that the mortality lifespan of a patient is as heavy as diabetes, social determinants of health. So we will talk about this going forward. That's part of what we do, but for the sake of time, let's just keep going.
Almost as if you're your zip code. Wow.
You kind of alluded to this earlier, Dr. Erdik, with the idea of like the multiple conditions for the patient. So
Absolutely. So here's one, very caricatural example. So, a lady with four, diagnostic conditions, four disease states, 12 symptoms, 22 medications, 20 healthcare providers that are around her. So there's a lot of ground to cover, and unfortunately, some of these people are by themselves. So imagine she has to take care of all this stuff. So, or family, but family have their own thing going, but if people have family, that's fine. But here we're talking about, staffing somebody who will be taking care and making sure every one of those care gaps that Dr. Friedel alluded is opened and closed. Because if it's open and left open, that's leaving the wolf with the door open, that it can walk in. So the idea is to close those care gaps. So I'm sure you have providers. They have many Miss Marias. So we want to help Miss Maria, every Miss Maria out there. So
I hope that none of our attendees are named Maria.
So yeah. Here's for the sake of time, I mean, we can digress with more jokes, but for the sake of time, let's talk about cost savings. So we have here 1,668. Those are the cost savings per patient per year when we embark for diabetes, as an example, in chronic care, in population health initiatives. So we're talking about total costs here, but then if you break it down, we're talking about outpatient costs, drug costs, acute care costs. So it makes sense. I mean, these are numbers that have been, churned out of data. So it totally makes sense. And here, if we go into the quality adjusted life year, quality gained, and that can also be, put a number. So whenever you're doing prevention, you're saving money. And whenever you're acting on something which is costly, you're saving a lot of money. So like, for instance, just intensive lifestyle modification to prevent type 2 diabetes, you're looking at $1,500 of quality.
It's really good. I mean, US is now paying almost up to 200,000 per quality in some cases. So you again, our costs are skyrocketing. So 1,500, sign me up.
And yeah, of course. So with the perspective there. So yeah, if we look at self-monitoring of glucose, type 2 diabetes, 6,900 of quality. And then other diseases that are very heavy, because patients going to dialysis, for example, chronic kidney disease costs 21,000, per quality, compared to no screening. So prevention is the name of the game going forward. And so we, for the sake of time, again, we raise the bar. So here we are talking about NPS rating and member satisfaction and engagement. So we are talking about we outperform the 75%, and we've been doing better. And we want to beat ourselves at our own numbers. So we want to go further than that. So that takes some.
Well, that's that quality control I was telling you about before. We're constantly trying to improve, and we're always watching ourselves as well in order to make sure we're providing the best possible service that we can.
Totally. So dedicating the same nurse for the same patient, making sure there's a bond that's created. That's what makes, for being engaged, and we have better outcomes. No, more numbers. So we have good numbers. I mean, the numbers speak for themselves. You can look them up on our website too. HbA1c levels, we're doing better than commercial HMOs and PPOs. We are plus 44% ahead, plus 11% for A1C control under 8. And over 9, we have 0. So we try to push that in the right direction. Same thing for Medicare. We have very good numbers, plus 65% over the Medicare HMO numbers, plus 15% under 8%, plus and plus 75% over for the over 9. So we're doing pretty good with the diabetes. In fact, that's the number one disease. If you look at New York City, there's a lot of diabetes patients. I mean, I'm sure you will agree.
It's only going to increase.
Of course, always linked. You pretty much linked. All right. So
That's like
let's
a
go down this slide by slide. Okay, I'm just kidding, guys. No, this is our clinical protocols. This is just one example of the algorithms our nurses are trained on to follow. So you can already see a lot of work, time, effort has been put into this process in regards to the program that we have set up. You'll notice the red dots. Those are the care gaps that I was telling you about from before. So if it ever gets into the scenario where it reaches one of those, our nurse knows that they need to report this as a care gap into our system. And so I'm not going to go into the details, but you can see, of course, just how complex this can really be.
Yes. So being staffed here, it's a no-brainer. So you have more people helping you with more quality. It's impossible to, imagine that's one.
And honestly, if you ever want to sit down with me, I would love to go over this. We'll take an hour out of our day. You just let me know. And
just 1 hour, is that it? Sure.
That's it. Yeah, I'm going to give you the abridged version. If you want unabridged, that'll probably be 3 or 4 hours.
So moving forward, go ahead.
So we've been alluding this actually the entire time. It's all about, those clinical outcomes and improving those clinical outcomes. And you can see if clinical outcomes are improved, you're going to reduce costs on insulin, hospitalization costs, ambulance transportation, all these things. It's pretty amazing. And so that's really what it comes down to. I want to leave this with, this is the most amazing thing when I'm with a client, when we're able to map out their entire patient population and they know the exact number of patients that have diabetes type 2. Then they know the exact number that have a hemoglobin A1C of 9 or above or below. It's an amazing, powerful clinical tool to be able to actually see your entire patient population and make some broad stroke changes to improve patient outcome in a more macro sense. So it's really one of the reasons why I enjoy doing what I do. Truth be told, it really is.
And just to mention the numbers, so we are value-based. So these are the numbers that we have to show. It's not that we like to show, because if we don't show them, we don't get paid. So that's as simple as that. So it's pressure to perform, and we welcome the pressure, but it's not just welcoming the pressure. This is the way we do it. So we are value-based. These are the numbers, and we have to show these numbers. And so that speaks for itself.
It really does. And thank you all for your time. I know that we do have some questions from the group. So if we want to start the Q&A, let's do it.
Yes, I have 3 questions so far. And then when more questions come in, I'll let you guys know. So I got one for me. So one of our callers is saying, caller number 1, my payment got cut last year due to MIPS scores. What does that do with CCM? So let me take that. So depending on what you selected in your MIPS, we can definitely improve the outcomes. So let's say if you selected diabetes, HbA1c, and your patients are not well controlled, CCM is your answer, right? So basically, we can custom tailor what you're reporting for MIPS based on what the best approach for your patient population from a chronic disease perspective is. There's no one right answer here. It's a custom order solution. So we're building you a Rolls Royce here with hand stitching and every single color you want. If that doesn't clarify, send me more in the chat, and then I will get you in touch with the right people in CCM. And then we have one question. I think this would be for either Dr. Jayaswal or Dr. Friedel. Says, wait, I thought I had to provide the CCM. Can it be subcontracted? And I see you're in Puerto Rico. So how does that tie in?
Yeah, so of course, you can do the CCM. I've met several providers doing them, and then I explain to them, you're not, as doctors, we are trained to do certain things, and then nurses are trained to do certain things. So if you start doing the job of a nurse, then you put her out of job. And right now, it's not even the case, because nurses are very hard to find the market, which brings us to a very important point that our federal grant allows us to be staffed for another 2 years, I think. So we are staffed right now with nurses, NPs. So she will be doing it. We will be assisting. And of course, there's Dr. Friedel, territory liaison. There's the technology.
Of course.
So it's a turnkey solution for you. This way, you do not have to worry about this, and you can have either more free time to read a book, to sleep, to do something else, and have this taken care of in a manner that is compliant, is also airtight. That is, if God forbid you have an audit, because it can happen. We're talking about federal tax dollars here, so you have something that is recorded, audit proof, and you don't have to worry about all that. You can do your clinical work. And what was the second part?
Dr. Jayaswal, maybe I can fill in some of that gap.
Sure.
So the federal grant is for 5 years to create 741.
Stan, let's
Well,
introduce
yourself, please.
Oh, I'm sorry. I'm sorry.
Exactly.
Go ahead.
So Mr. Gutkin is our chief operating officer, so he runs the show.
So I operationally I do, clinically is Dr. Jayaswal, but let me go ahead and answer that question. The grant is for 5 years, and it doesn't mean that the labor resource will go away in 5 years. It means that we're subsidized for 5 years from the government to create 741 nursing jobs. Yes, we are in Puerto Rico because we must be on U.S. soil, and that is one of the CMS requirements to perform the service. We do enjoy the benefit of working directly with colleges and having the nursing component to be at our disposal and provide the nursing component where there's physically shortages everywhere through the country. So I hope that answers the question. You're able to get these nurses because we're able to get these nurses at reduced cost, and we're having a lot of help. So
Yes.
you're leveraging the labor.
Right.
You'll
Absolutely.
find a lot of providers that are ultimately using LPNs and MAs to perform their service activities. We found that there isn't enough depth on the clinical knowledge on MAs or on the LPNs to engage these patients clinically and to keep the engagements at 95% from months to months. You do need to deliver clinical value. Otherwise, you're going to lose the attention of the patient, and the patients will grow fatigue, and your program won't deliver the clinical outcomes that you would expect. It is our job to deliver them, so we need to create consistent value, and not only value to providers, but value to our patient population. It is, after all, patient-centered. I hope that answers the question. Dr. Jayaswal.
Yes, yes, absolutely. So, a nurse practitioner is, if I have to give my patient to anyone other than a doctor, it'll be a nurse practitioner. So here we're staffing you with NP. So
No. So Dr. Jayaswal, our ANDs, nurse practitioner, that's a separate program, but our ANDs all throughout for care management, for remote patient monitoring. And as we're entering into behavioral health integration, you're looking at clinical social workers and whatnot.
Yeah, that's the BHI, which is a separate part of the CCM program,
yes.
the COCM, where we get into the behavioral health integration. We can talk about that.
Okay.
Dr. Erdik, are there more questions from the crowd?
Yes. So it's asking whether there are any restrictions for the CCM diseases, and then if the patients have a copay in all of this.
Yeah.
Like how, I guess the better question would be, how does the patient tie in? What do they need to do?
Yeah, let me go ahead, Dr. Jayaswal, if you don't mind, I can go ahead and take that one.
Sure.
Absolutely, if the patient only has, say, Medicare or Medicare Advantage plan, and they don't have a secondary insurance, they will be responsible for the copayment. If it is a dual eligible patient, then ultimately the secondary would pick up that copayment, and there will not be cost barrier for the patient. So you'd find that if you're in, let's say, if you're in New York, if you're in the city, majority of the patient population will have dual insurance and dual eligible patients, so they will not be responsible for the copayment. But as you move over to suburbs, it varies.
I mean, I guess, yeah, the better answer, other than the financial part, is that the patient only needs to tie in and buy in. Like, you don't want the patient hanging up on the nurse. You want the patient to be an active participant.
Sure. But I thought there was a second part of this question. So one was
whether there were any restrictions on what chronic care management diseases are.
Absolutely. So definition of chronic condition is a condition that expected to last 12 months or more, and could lead to a hospitalization or worsening, or to mortality. So you want to focus on ultimately disease states that matter. Dr. Jayaswal or Dr. Friedel, if one of you guys want to take on and give an outline of the common diseases that we educate patients in and cover.
Of course, yeah, let me take this one. So, I mean, the common two that we really C primarily is diabetes and hypertension. Those are our two main ones, and then followed quickly by depression and anxiety, especially with the pandemic. There's been a lot of isolation, so there's been definitely an uptick in regards to mental health issues as well.
COPD.
Yeah.
There's about umbrella 15 to 17 major disease states that we cover, but just like
I really want to hit the highlights.
Yes, mentioned those are the popular ones.
Mm-hmm.
Yes, of
And
diabetes, blood
then
pressure.
can make a dent, I guess.
Mm-hmm. Dr. Erdik, any more questions from the crowd?
Yes. So they were asking about the 20-minute requirements. So, well, I guess I'll take that one. So the 20-minute requirement, it's not necessarily for the clinicians. So it's for the non-clinical activity. So meaning usually it's the time our nurses will be spending with the patient and then every associated aspect of that. That sort of answers that. So for that 20 minutes, you do not necessarily need to be doing anything.
If you don't mind, let me add on to that. So physician has the oversight, and obviously you need to close and resolve all your medical gaps. When you're looking at 20 minutes, essentially, if you're thinking of chronic care management, you have to be thinking of time blocks. So every time block is 20 minutes. So a single patient might have one time block, which is 20 minutes, two time blocks, which is 40 minutes, or three time blocks, which is an hour. It obviously depends on the complexity and what the patient is presenting in any given month. And based on the clinical requirement and the oversight educational program that you're going to have us do to the patient population. So if you want us to focus more on patient education, if you want us to survey the patient population, according to what you're already doing within your practice, we'll be supplementing what currently is necessary for the patient population to keep them out of a hospital. So based on those clinical requirements and based on what the patient is presenting with, will dictate the amount of time that needs to be spent for any given month. The beauty of our platform is that every single click, every single second, and every single box is fully recorded within the platform. You will have complete access to all the phone recordings within the click of a button, 24 hours. You're going to have full audit trail of all documentation that has been conducted on a patient's profile, and not a single patient will be approved until you physically sign off your care plan, and Dr. Friedel will be there to assist you and guide you on how to get that done. But it's very, very easy. Essentially, you'll be doing quality control on top of our existing quality control. And the way we like to have our service be addressed as, when we're going to ask you, how is our clinical team doing? We only expect one word: seamless. Because if it isn't seamless, it's seamless.
We're doing it wrong. Yeah. No.
Absolutely.
Exactly.
Yeah.
Because we're not there to make more work for you. That is not the intent at all. And I can go into all the details and steps of onboarding and all that, but I think we should save that for another time.
Yeah.
And
We'll
for
have
people,
time to talk
We
in
have one
person.
more question. It's saying, if you're doing all the work, do I really need to see the patient? I guess Stan was kind of answering it, but ultimately the physician is captain of the ship, right, Stan?
Yeah, 100%. And the idea is that we're covering the patient in between the visits. So we're not covering the patient instead of the visit. Our job is to identify gaps and illustrate those gaps and facilitate the patient comes to you, and ultimately you need to close those gaps. So this is not instead of your office visit. This is in between your office visits. So you're being proactive and you're not just reacting to what already has occurred.
supplemental.
Sure. We got one more question. It's asking how CCM and RPM is reimbursable.
Sure. So I think that one needs to be answered generally now, and we can absolutely have a one-on-one and walk you through the CPT codes and the description. But it's a fee for service, and there's value-based component to it as well. So every activity is billable activity as long as it's approved by you, and we can go ahead and do a financial feasibility study specifically for your practice 101 and see if that works for you, as well as see if a strategic partnership works for us as well. Feel free to tap on Dr. Jayaswal, Dr. Friedel, and they're going to facilitate that for you.
Yeah,
Mhm.
absolutely.
Exactly.
Yeah, we have Dr. Erdik amongst us. So yes, point to be mentioned is that the reimbursements have gone up in December 2021, which
It's
means
actually very well reimbursed. Yes.
so Medicare is wanting us to go in that route. So yes.
So I want to underline that it is very well reimbursed, but what everybody has to keep in mind is you need to create a healthcare cost saving. So in the end of the day, when you look at the reimbursement that your practice will receive versus the amount of money that your practice have saved for their insurance plans, you need to make sure that you're creating value. You need to make sure that you're creating healthcare cost saving. The quality of the care for the patients goes up. That is
Exactly. It's not just to bill it, but like you need to show something for it ultimately, I guess.
Absolutely, yes, yes.
Yes. Any other questions, Dr. Erdik?
Nothing has come up yet. Let's maybe.
So
A lot of good questions.
if we addressed all the questions, I think it's time we need to wrap up. And please feel free to tap on us, and we'll do one-on-one sessions and absolutely address all your questions and concerns. And evaluative partnership is a right move.
Yeah,
That's
pleasure meeting you all today for this podcast, and then thank you all to our attendees who spent their afternoon with us.
Evening.
It's been a
Yeah, it's
pleasure.
already. So yes, thank you everybody.
Thank you
Dr.
for your
Friedel and
time.
I stand, Dr. Erdik, and we'll keep this conversation going.
Well,
Have a good evening.
Thank you. And then as Dr. Jayaswal has mentioned, find us on social media. We have trainings. We have all the tools you need.
thank you.
All right. Have a good night, guys. Bye-bye.
Take care.